Welcome, everyone. Today, we're diving into one of the most high-stakes, fiercely debated topics in modern rheumatology. We're talking about systemic lupus erythematosus, or SLE. And specifically, we're zooming in on the clinical debate surrounding glucocorticoids, which you probably just know as steroids. Now, for decades, these drugs have been the absolute cornerstone of lupus therapy. But today, well, physicians are really divided on how to manage them once a patient's disease is finally quiet, or quiescent. Okay, so let's get right into it. The ultimate question facing doctors and patients alike is actually pretty straightforward. In quiescent SLE, to withdraw or not to withdraw? It sounds simple enough, right? But it actually represents a massive clinical dilemma. On one hand, you've got the incredible, literally life-saving efficacy of these drugs. But on the other hand, you have the severe, long-term risks that come with taking them for years on end. So how do we balance the two without putting the patient at risk?
To understand this tightrope walk, here's our agenda for this explainer. 1. The glucocorticoid dilemma. 2. The case for complete withdrawal. 3. The risk of lupus flares. 4. Comparing two clinical approaches. And finally, 5. Current guidelines and synthesis.
Section 1. The glucocorticoid dilemma. Efficacy versus toxicity. Since the 1950s, the contrast here has just been stark. Glucocorticoids have been widely praised for providing miraculous, super rapid remission for active SLE. Honestly, when a patient is having a severe flare-up, there are just no other drugs that can induce active remission this quickly. Their anti-inflammatory power is immense. But there's a really heavy price. Prolonged, long-term use of oral glucocorticoids virtually guarantees irreversible organ damage. It is a textbook double-edged sword. So the damage from glucocorticoids, or GCs, is highly dependent on two main things: the cumulative dose, which is how much you've taken overall, and your total time of exposure. Studies clearly show that high average daily doses directly lead to some really severe health issues. We're talking cardiovascular events, osteoporosis, bone fractures, and osteonecrosis. In fact, medical researchers have even calculated specific cutoff points for average daily doses. For instance, hovering above 7.38 milligrams a day for a year, that can accurately predict organ damage 5 years down the line. It's basically a ticking clock. Section 2. The case for complete withdrawal. The Crucis approach. Now, the cornerstone of this pro-withdrawal approach actually kicks off right at the beginning of treatment, using something called methylprednisolone, or MP, pulses. So instead of giving a patient high doses of oral steroid pills for weeks on end, doctors administer intermittent, extremely high doses of intravenous glucocorticoids, often between 125 to 1,000 milligrams a day, but just for 1 to 3 days. Why do they do it this way? Well, this massive IV dose utilizes what we call non-genomic biological pathways. It delivers a rapid, potent, anti-inflammatory shock to the system, but it completely bypasses the specific genetic pathways that cause that long-term toxicity we see with conventional medium to high-dose oral pills. Pretty clever, right? Let's look at how this builds into a full strategy. The Crucis approach operates in distinct steps. Step 1. Hit the disease hard with those IV MP pulses to gain rapid control of the flare. Step 2. Because they use those pulses, they can then strictly limit the initial oral prednisone prescription to no more than 30 milligrams a day. Step 3. They rapidly taper that oral dose down to 5 milligrams or less within just 12 weeks. And finally, Step 4. Once the patient has achieved long-standing remission on that tiny dose, which sometimes takes several years, they attempt total withdrawal of the glucocorticoids. The ultimate goal here is absolutely zero steroids. But even the most passionate advocates for total withdrawal agree on one absolutely critical rule: it has to be agonizingly slow. Gradual discontinuation of prednisone over a period longer than 3 months is 60 to 70% safer than just stopping it abruptly. You literally cannot just stop taking it overnight. Protective background therapies like hydroxychloroquine absolutely must be maintained, and the steroids need to be tapered down 1 single milligram at a time to prevent shocking the body. Section 3. The risk of lupus flares. The maintenance view. 4 times. That is the statistic that sits right at the center of the maintenance argument. A 4-fold increase. That number comes from a landmark 2019 randomized controlled trial by Mathian and colleagues. They took SLE patients whose disease was completely quiescent, totally asleep and stable, and then they withdrew their final tiny 5 milligram daily dose of prednisone. The result? a four-fold increase in flare rates. 27% of the patients who stopped their low-dose prednisone experienced a lupus flare within a single year. And here's the real kicker. 91% of these patients were still actively taking hydroxychloroquine, which is that protective background medication. Even with that safety net firmly in place, dropping that final 5 milligrams of steroids caused huge spikes in major disease flare indices. So, for physicians in the maintenance camp, those trial results are a massive, flashing warning sign. Why? Because disease flares themselves are strongly linked to long-term, irreversible organ damage and a severely reduced quality of life for the patient. Flares aren't just temporary setbacks or a bad weekend. Some physicians argue that low-dose steroids, even after several years, still provide vital anti-inflammatory properties that basically keep the wolf from the door.
Section 4. Comparing two clinical approaches. So we have the Crucis approach, a rapid taper down to zero, utilizing those early IV pulses with the primary goal of preventing the irreversible toxic damage caused by the glucocorticoids themselves. And in contrast, we have the Pite-Salpêtria approach, utilizing early immunosuppressants to allow for a long-term low-dose maintenance of 5 milligrams a day with the primary goal of preventing devastating, damage-causing relapses of the lupus. Now, it is incredibly important to note here that neither side is wrong. Both of these approaches are completely valid, they're backed by deep clinical logic, and they're aimed at the exact same ultimate outcome, which is preventing long-term harm to the patient. They just prioritize different primary threats.
Section 5. Current guidelines and synthesis.
If we take a step back and look at the latest guidelines from major rheumatology and kidney organizations around the world, a really powerful consensus actually starts to emerge. The American College of Rheumatology for 2025 targets under 5 milligrams a day. The European Alliance of Associations for Rheumatology, EULAR, in 2023 updated their target to 5 milligrams or less. And the KDIGO guidelines for lupus nephritis suggest tapering down to 5 milligrams quickly. So what we're seeing is a universal global agreement to drastically lower the acceptable maintenance dose to 5 milligrams or less. They aren't strictly mandating a drop to absolute zero for everyone, but they are absolutely unified in getting the dose as low as humanly possible while incorporating elements like the IV pulses and universal hydroxychloroquine.
So the crucial point we have to take away is that there's just no one-size-fits-all answer here. Pragmatic management has to prevail. Today, the standard of care requires individualized, shared decision-making between the doctor and the patient. For example, a doctor might lean toward total withdrawal if a patient is approaching menopause, has high cardiovascular risks, or is highly prone to infections. Basically, all situations where steroid toxicity is especially dangerous. Conversely, they might lean toward long-term maintenance if a young woman is planning a pregnancy, which we know is a high-risk time for flares, or if the patient has pediatric onset lupus or pre-existing kidney damage that must be fiercely protected from any relapses. This quote perfectly captures the modern synthesis we're talking about. Dr. Lisa Sammaritano, the lead author of the newly released ACR 2025 guidelines, states, the major updates include minimizing glucocorticoid exposure to less than 5 milligrams of prednisone daily. We also emphasize the role of shared decision-making between clinicians and patients because multiple factors may impact choice of therapy. It really is all about combining strict dosage limits with deep personalization. Which leaves us with this final thought. Managing a chronic autoimmune disease is a delicate, ongoing balance. Whether leaning towards aggressive withdrawal or protective low-dose maintenance, the goal is always protecting the patient's future. How will you and your healthcare team navigate the tightrope between preventing medication damage and stopping disease flares? I really hope this explainer has given you the structured clarity you need to understand this vital medical debate. Thank you so much for joining me, and keep asking those big questions.